Welcome back to Reclaim Your Stride. I'm Dr. Michael Wynn and wanted to talk to you today a little bit about a minimally invasive type of knee replacement known as the SubV knee or subvastus knee replacement. So SubV stands for subvastus, which means coming under the musculature instead of going through the musculature. And I want to explain that today so you can understand what a traditional knee replacement approach looks like and what a SubV approach looks like, and understand the potential advantages of the differing approaches. So this is a knee replacement surgery, and whether we're doing a traditional approach or a SubV approach, what we do to the joint itself as far as small cuts on the bones, placing the femoral cap or femoral component, tibial component, and the plastic spacer in between, all of that remains the same. So we're putting in the same type of implant. The question is, how do we access the knee in a minimally invasive way that allows for quicker patient recovery? So in a traditional knee replacement, imagine this is just the skeletal knee, but in a real knee, there is muscle covering all of the front of the knee. The major muscle is your quadriceps muscle, which is the large muscle on the front of your thigh. This is your quadriceps tendon, and this is your patellar tendon with the patellar kneecap behind it. And the quadriceps really pulls this entire mechanism, allowing the knee to flex and extend. In a traditional knee replacement, the approach is what's called a medial parapatellar arthrotomy, which is where the surgeon will go and make a cut in the quadriceps tendon and cut alongside the patella and essentially gain exposure to the knee by opening the quadriceps into two parts like a book. That allows exposure to the joint, the bony resections can be made, the knee replacement can be placed, and at the conclusion of the procedure, the quadriceps tendon incision and the quadriceps incision of the muscle is sutured closed. In a SubV knee or subvastus knee replacement, the surgeon will come alongside the patellar tendon and then go underneath the vastus muscle, part of the quadriceps muscle, leaving the quadriceps tendon completely intact. The surgeon will mobilize the muscle and then allow the entire muscle and tendon to slide to the side as the knee is flexed. This allows exposure to the knee without violating the tendon or the muscle. The knee replacement is performed, and at the conclusion of the procedure, the muscle and tendon are allowed to slide back into place with minimal violation of the soft tissues around the knee. So for SubV knee patients, the potential advantages that I've seen is the potential for less pain, the potential for better strength, and the potential for quicker recovery, especially in the first several months after surgery. A question I get from many patients is, who is a candidate for a SubV knee replacement? And patients who are candidates typically have reasonable range of motion, so we like to see at least 110 degrees of flexion, and that ensures that we have enough mobility to mobilize the quadriceps, and typically have not had significant surgery on the knee before. Patients who've had significant surgery, such as a past knee replacement, have too much scarring to get the muscle to mobilize. Most other patients are candidates for a SubV approach to knee replacement. So again, you can get a great result with both a traditional approach and a SubV approach, but I do feel that the SubV approach is less invasive and has the potential advantages of improved recovery times for patients, less pain, and a faster return to activities.